We now have a talk on approach to parotid nodule by Dr. Shivakumar Thiagarajan, currently an associate professor in the Department of Head and Neck Surgical Oncology at Tata Memorial Cancer Center, Mumbai. Sir.
So after an exciting debate and all the arguments that were there, so we'll just try to put things in perspective again, and we have seen most of this being mentioned in various talks since morning, and this will just be a recapitulation of what's being said. And again, going back to some of the questions that was being discussed just a few minutes back. So we're talking about parotid nodules of all sizes. The discussion was for these, and now we see most of these as well. All of you all would see that, and we know parotid malignancies are extremely heterogeneous, with benign to very high-grade malignancies, and it's a rare tumor. It falls within the rare malignancy categories, and so are the evidences. So evidences that comes for salivary gland malignancies cannot be, of the highest level, but definitely we do have enough evidence. And parotid tumors are far more common. We all know that. We have seen that mostly it's benign in parotid, and smaller the gland, more chances of malignancy. So history taking, because it was an approach to parotid nodule, and we have a lot of fellows and residents out here, we must understand that history also plays a very important part in your approach towards any nodule. So location of the tumor, and so we know parotid is mostly benign, submandibular 50% chance of benign malignant, sublingual minor salivary gland, more chances of malignancy. Symptoms are very essential, whether usually it is painless swelling, and recent onset of pain, rapid growth, facial nerve palsy should indicate malignant tumor. And we should always, in any parotid nodule also, as a part of completion of your examination, you should just examine the eyelids and scalp as well, so that you don't miss out on some tumors there. It could be metastatic node in the parotid for all you know. And examination of the neck is a very essential aspect, and fixation, and you should see whether the parotid lesion is fixed to the underlying structure. That is a very important part of a clinical examination. That again gives you some clue as to what's the nature of the tumor that you're talking about. You're looking into. And examination of scalp, as I said, for completion. And what are the risk factors? We know the risk factors for most of our tumors. So for parotid nodules, tumors, salivary gland, major salivary gland tumors, overall it remains unknown. It's not very clear. Warden's tumors associated with elderly individuals who are classically known to be smokers, and history of ionizing radiation and ultraviolet radiation has been associated with parotid malignancies, neoplasms rather. And there have been certain reports on genetic associations as well. Now imaging, we saw a lecture on imaging. I think many of us would start with an ultrasound at most of the centers, but when can it actually be done? What are the pros and cons of it? So maybe the initial investigation can perform a guided FNA, which would help you get a better yield, and it's easily available. But there are lots of certain disadvantages in the form of its operator dependent, deep lobe or the parapharyngeal space involvement cannot be assessed, and of course involvement of the skull base, the perineural spread, all of that cannot be really assessed by your ultrasound imaging, and of course bone involvement. Now the other imaging is a CT scan. Do we routinely do a CT scan? Of course it's not recommended on a routine basis. It is done if you're suspecting any bony involvement or by the tumor. So most often we would resort to an MRI, and it helps you rule out perineural spread, skull base involvement, assess the deep lobe, parapharyngeal extension, intracranial extension if any, and also it will help you evaluate the neck nodes. So it will be one-shot evaluation for the entire parotid gland as such, and as the radiologist put, based on the various patterns, you can also have an idea as to what kind of neoplasm that you're dealing with. And there was a question as to whether you should be doing a PET scan if you're doubtful to rule out whether it's benign or malignant. So should we do that? Now, most of what I'm talking here is based on the ASCO recommendations, and why I'm using that is because it is based on certain, a thorough literature review of what is available till date. It was released in, 2021 after a thorough literature review. So that's the best we have as far as the evidence is concerned. So whatever I'm discussing right now, and of course what was discussed most of the time till now was based on that. So we can consider a PET scan if you're dealing with a high-grade malignancy, if you have the diagnosis already, because many a times you would have a patient coming in with some sort of an open biopsy or an inadequate surgery done, you have a histology of high-grade, then before you do a completion of the treatment, you would probably want to do a PET scan to evaluate the patient fully. Upfront, if you have the diagnosis, well and good, but then we know that it's not often possible. Advanced stage disease, recurrent disease, and PET scan is not useful to differentiate benign and malignant. You have a FNA, it is inconclusive or slightly pointing towards malignancy, and you want to differentiate that with a PET scan, that's not the way to do it. PET scan should not be used for that reason. So tissue diagnosis, after the imaging, I think most of us will do an FNA to differentiate between salivary gland malignancies and non-malignant lesion firstly, and then between benign and malignant. Now, do we do an FNA or a core needle biopsy is the question many a times. I think most often FNA would be a much more doable investigation. And now, what are the evidences that we have for that? So it helps us differentiate benign versus malignant definitely, but the sensitivity for this is slightly lesser compared to inflammatory and non-inflammatory regions. And it is, why do you need an FNAC? I've heard many people say, why FNAC? Just go and operate and get the tissue out. But that may not be the best approach, because that will help you in counseling the patient better and also to plan your surgery better as well. And we have evidence to say that, and in this paper, when you had a by Lin and Bhattacharya, when you had a pre-operative FNAC, they ended up performing a higher rate of neck dissections, and they had a better margin clearance. So it helps you prepare better for your surgery. And you have evidences saying that this is a bigger sample size wherein the preoperative FNAC changed the surgical plan in close to 20% of the patients. So it's very essential that we do an FNA. Now what you get of it is a different matter, but we need to do an FNA to plan things better. Now this is a systematic review saying the higher sensitivity and specificity for an FNA because it's a good investigation to begin with. Now, when you do an FNA, I think Madam also spoke about the reporting aspect of it, but the ASCO guidelines recommends that we should report the risk of malignancy using a risk stratification scheme, and the current standard reporting scheme that is available to us is the Milan's system for reporting salivary gland cytopathology. Now initially, and this has been modified recently, initially it had 6 categories, now we have 7 categories with a few subdivisions. Now these are the categories, and it's an interesting article to read as to how they zero down to this. And now the problem with Milan's system is, and I mean they try to bring in a system such as like in Bethesda, to have a clear-cut, a risk of malignancy for the nodules. But then we are dealing with 4 types of malignancies there. But here you have a plethora of diagnoses, and which not just requires cytomorphological assessment, but you need further evaluation using immunohistochemistry and various other markers that are essential. So that's where Milan's system will be difficult to implement, but nevertheless, I think it should be done to begin with, so that we'll have some sort of a common language that we can talk across institutes. Now, that is exactly what we wrote in this letter for the previous systematic review that was done. And there was a question as to how FNA is useful. Now we looked into our data of patients who underwent a total parotid surgery, which was superficial and total conservative, and who had pre-op FNA done. And at TMH we have disease management group, and we have pathologists who are specific to a DMG. So we have head and neck pathologists, so to say, whose major part of their work is dealing with head and neck pathology. Now, so we looked at, if they look at the FNAs, are they able to report better compared to those who are not specifically reporting head and neck tumors. So there was definitely, when head and neck pathologist reported the FNA, their correlation with the final histopathology was definitely better compared to when it was done by a non-head and neck pathologist. That doesn't mean when a non-head and neck pathologist reported it was inferior, but when a head and neck pathologist reported it, it was slightly better. The kappa value that you see was definitely better. And also the frozen section was used, when it was used for asking for a grade, the head and neck pathologist was more often able to tell you the grade, which probably helped the surgeon in deciding on the neck dissection or whatever the reason might be. That reason we don't know. I'm not talking about that, but the pathologist was able to tell more often the grade when they were head and neck pathologists. So for more details, I think we just go through this paper. And we had another paper wherein the pathologist went back and reported the FNA based on the histopathology that we have. And we have the risk of malignancies at our institute. But you can see in literature you have 19 to 12%, but here the type 1, the 1 and 2, the percentage of malignancy is higher. That could be because of the bias of referral bias that you have for a tertiary cancer center. So apart from that, the rest of the percentages are good. But why I mentioned here is that you need to know the risk of malignancy that is prevailing in your institute. That may not be as it is reported in literature. And for starters, we should start reporting it using the Milan system so that we get these numbers, we populate it, and we need to know what is the risk of malignancy for our patients in this part of the world. What we have so far is what is there in literature from what has been reported in Europe and other parts of the world. So I feel this is the beginning, and I think more and more we should come out with reports wherein we look at the risk of malignancy using the Milan system. And core needle biopsy is not done always. It is done in certain situations where the FNA is inadequate or concerns of lymphoma is there, or when the tumor is deep-seated, such as in the deep lobe tumor. So when you have to do an image-guided biopsy, you might as well do a core biopsy. And the concerns for core biopsy is implantation and damage to the nerve and hematoma. And this systematic review of close to 2,000 patients really puts an end to all those doubts that we have in mind. So when essential, this procedure can be done safely. Now we have seen as to what is the extent of the surgery. Surgery is the treatment of choice. There's no doubt on that. We have debated enough about enucleation, extracapsular dissection, adequate and superficial paratidectomy. If at all these should be attempted in benign tumors. These are ASCO recommendations, and that recommendation 2.4, which was being debated, the 2.4, the last two lines which Abhishek missed, says that in consideration for total paratidectomy in high grade and advanced stage cancer, and it ends there, and the level of recommendation is high, and they say that it can be done there, and there ends the matter. And these are the various surgeries that should be considered for malignant tumors. As the minimum surgery that we should consider for malignant tumors as per the recommendations of superficial paratidectomy is what is being said. Of course, we have debated the nuances of when we can do anything lesser. I'll not go into that again. And this is the European Salivary Gland Society classification. I think it's important to know this, but I think they have come with this classification just to make the extent of surgery a bit more, definable across institutes, and when we report it, so that we speak a common language. I'm not sure if it serves any additional benefit other than that. Now, the frozen section. So there was question as to when do you use frozen section. We have again debated on that, and if when you don't have an FNA diagnosis, you can do, or it is inconclusive, a frozen section might be helpful. And to support immediate alterations in your intraoperative management, like facial nerve sacrifice, extent of resection, or the need to do neck dissection. And decisions such as facial nerve resection should not be based on indeterminate preoperative or intraoperative diagnosis. So that is very clear as to what the recommendations are. And the sensitivity and specificity for using frozen sections for various indications is in excess of 90%, so that is not a concern. And at our institute, when have we used frozen section? So when we have a Milan's reporting of greater than 4B, that is, if it is 5, 6 or 7, then the chances of it being malignant was far higher. So there was no added benefit of using frozen section. So frozen section helped when it was anything lesser than 5. And most of the time we have used frozen section for primary diagnosis, or for margins, or for the next nodes. So essentially level 2 sampling, and if that is positive, then we would go ahead and complete the neck. The facial nerve management, again, just to complete the slides, should perform facial nerve preservation in patients with intact preoperative facial nerve function when a dissection plane can be created between the tumor and the nerve. and should perform resection of the involved facial nerve branches in patients with impaired facial nerve movement preoperatively, or when branches are found to be encased or grossly involved by a confirmed malignancy. So, and we have debated about this. So this is what most of us would probably end up doing, and this is what the recommendations also suggest. And margins, the other aspect is in major salivary gland tumors such as parotid tumors, there is no recognized definition of a close margin, like negative, close or positive margin. It's a contentious issue. It's all because of the facial nerve that might go through the tumor or close to the tumor. So you want to save the function of the facial nerve. Many centers use 1 mm as the cutoff value for close margin, or anything more than 1 mm is considered adequate, and we have evidence for that. And this is the latest article from MSKCC, which shows that in the presence of a positive or a close margin, the disease-specific survival is poorer, and the local regional recurrence is almost same for close and negative margin, and definitely when it is positive they have a poorer outcome. So we should take all efforts to have a clear margin, that is, it should be more than 1 mm for major salivary gland tumor. When I mean major salivary gland tumor, we are talking about parotid tumor. And remember, the concept of margin in parotid tumor is contentious, that we need to keep in mind. Neck, we have seen for N0 neck, when should we do a neck dissection? The recommendation is to consider neck dissection in T3, T4 and high grade malignancy. And what levels do you address? Level 2 and 4, 2 to 4. And we can do a level 2 sampling, send it for frozen and go ahead. That is not the recommendation though, but this is what the recommendation says. And for N+, there's not much of controversy. Adjuvant RT, high grade tumors, and now the recommendation says for all adenoid cystic carcinomas, you should go for adjuvant radiotherapy. But that again can be contested. Positive margins, PNI, lymphatic and vascular invasion, N+, T3, T4 recurrent tumors. In the setting of patients undergoing adjuvant radiotherapy, the addition of concurrent chemotherapy may not be routinely offered outside of a clinical trial. There are currently 2 randomized controlled trials that are going on, and the results of which could be expected by around 2028 to 2030. So till then, we don't have strong evidence to add concurrent chemoradiotherapy in an adjuvant setting. And this is the outcome of dealing with parotid malignancies at our center. And of course, tumor grade is a very important factor that determines prognosis. Mucoepidermoid malignancy is common, followed by pleomorphic adenoma. And it was being said grade is more important than the stage, and the prognosis of the patient is determined by the grade. But then we didn't have any compelling evidence. It was being said there was nothing in the form of evidence. So what we did was, we did we looked at the SEER database, and we factored in the tumor grade with the T stage, and we did the staging, and that clearly shows that when the grade is included in the staging, that gives a good hazard discrimination, and in predicting the survival for these patients. So for the first time, we have evidence to say that when grade is factored into the staging, it really helps us look at the survival of the patients. Till now, from Ronald Spiro's days, it was being said we didn't have conclusive evidence. Now we do have, and there's one other series from, I think, if I'm not mistaken, from MSKCT after this, which also says that. And this we validated in the SEER database and in our own database, and it was identical. So definitely grade has a bigger role than the T stage alone in salivary gland malignancy. So to conclude, salivary gland neoplasms are rare, parotid neoplasms are common among these salivary gland neoplasms. FNA and imaging, in most cases MRI, are essential, and FNA is to be reported using the risk stratification scheme. Core needle biopsies may be considered in select cases. Superficial parotidectomy is the minimum surgery for parotid malignancies, apart from the nuances that we discussed. Adequate parotidectomy can be considered in benign and a select low-grade malignancies. And the concept of margins in parotid malignancies is contentious. We should aim for a margin greater than 1 mm. Neck dissection for N+, high-grade tumors and T3, T4 cancers. FS has some role in parotid malignancies, that is frozen section. And preoperative facial nerve function and intraoperative findings are important in their management. And adjuvant treatment can be considered in T3, T4 N plus high-grade tumors and when the margins are less than 1 mm and PNI, and no addition of chemotherapy is to be considered outside of a clinical trial setting because the evidence is not robust. And stage, along with the grade of the major salivary gland malignancy, has a significant impact on predicting the survival of patients with major salivary gland malignancy. And with that, I would like to conclude my talk and welcome you all to FHNO 2024. Thank you for your attention, and I'd like to thank the organizers for giving me this opportunity. Thank you.
Shiva, great talk.
Thanks, Abhishek.
Absolutely wonderfully encompasses all the current evidence about parotid. I just had one question regarding the TMS data when they compared the Milan staging with frozen section. Were the FNAC in-house?
Yeah, all the FNACs were in-house, yes. When we had the slides to review, that's when the patients were considered.
60% for non-malignant turning into malignant is pretty high.
Yeah, that is, as per the, this FNA that was done was based on the report, and then that was the percentage we have. So this is just the beginning. Now if we do it henceforth, and we're just standardizing the reporting system right now. So that could be the other reason.
At TMH, you can now look at different criteria to define those.
Maybe,
Yes.
maybe.
Shiva, nice talk. I enjoyed, and congratulations on so many studies. But you did respond to a comment I made, and you said that the guideline ends there. It's correct. But if you read the literature review, please read the
Yes.
last line. It says, so you try to make a point, and FUFA, a very important point that I'm making. It's not about what's written. You please read the report, and the last line does say, in light of recommendation 3.2, adjuvant RT, deep lobe is only done when the surgeon deems that it is not at risk.
Absolutely,
So
I
that's
agree with
the
you, sir.
important
I agree
point.
with you, but I just wanted to bring out the point that is the recommendation, and just to...
But you have to read
rest
the
of the
whole
curiosity.
recommendation. You can't just take out something, make a comment when you're a senior person speaking to others.
Right.
The point was not in good taste to make that kind of a comment.
I'm sorry if it meant that way, sir, but it just was trying to say what the recommendations are. Of course, the literature, review of literature is what you mentioned. I agree with that.
Read the recommendation.
I agree with that, yeah.
What is your opinion now about the ECS? Your opinion,
Sorry, ma'am, I didn't get you.
ECS.
Extracapsular spread.
What is your philosophy about ECS? It should be ever done?
Extracapsular dissection, that is.
Yeah.
I've never done it. I've never done it.
That message also you should give.
I've never done it. I would not recommend the minimum surgery I would recommend is an adequate paropterectomy at best. That should not be a first surgery. If a resident is starting his surgical training, you should not start with an adequate paropterectomy. You should start with a superficial paropterectomy to begin your training. Then as you experience, as you go up the ladder, you can probably attempt doing an adequate paropterectomy. That's what I would recommend as of today.
And that helps, as Ravi said, that suppose by chance this comes out as a low-grade mucoepidermoid carcinoma, you don't have to go again. You have done adequate surgery.
Exactly.
So even if with an incompetent or a less experienced pathologist, if you are working, and if they cannot give you a diagnosis of mucoepidermoid, and if it comes on the final HPR, you have already done the surgery. So my
Right.
question is, in India with a varied trainings and different group, every sector is not equipped with all the philosophies and experience. I think your message should be that superficial parotidectomy well done is a minimum surgery.
I would rather put it, you start your training with superficial parotidectomy and do anything less or more.
Let me, Jyoti, I'll respond to your point. I would have made it in my recurrent, but just to place it, you see the margin in parotid surgery, no one knows what's an adequate margin. The margin up to 1 millimeter is okay. So even if you do an extra capsular in a low grade and you have gone 2 to 3 millimeters beyond the areolar tissue, you don't charge in and reoperate the patient. Do you follow?
Sir, but
So that the margin is 1 millimeter in these tumors. So you may have to go. It's safer to do a partial. But the message should not go that you charge back and operate ki kam ho gaya surgery.
no. For example, sir, if patient has undergone an adequate parotidectomy outside, now it comes as a low-grade mucoepidermoid. that patient comes to me. Now I wouldn't jump in and do a completion paratreatment for that patient. I will stop there because I know very well that now if I go in, I have more chances of injuring the parotid. But if the same patient came to me the first time, I would have done a superficial paratrectomy for that patient. That is what I would do.
I'll show one slide in my recurrent. I'm giving a talk on recurrent.
Wait.
Presented of yours where you did the pre-op FNA compared with
Yeah.
final histology, which were the cancers that were most often missed on an FNA? Because what we've seen, we struggle often with either basaloid neoplasms like adenoid cystic being mistakenly reported as a highly cellular PA or something, or sometimes mucoeps which have a mucoid epidermoid component being read as PAs or Warthins. I don't know, what's your experience? Which cancers often got read as
So the
benign?
mucoepidermoid carcinoma is the most commonest. So that, I mean, there was nothing that we could come out with a significant value, statistical value as such. But as such, if you ask the commonest malignancy that was reported that way, it was mucoepidermoid carcinoma because of sheerly numbers. Sorry?
My says missed. Which cancer often gets missed on an FNA?
That we didn't look at. We didn't look at it. Our thought process when we started that study was to look at whether the pre-op FNA would help us predict malignancy in the post-op, how many percentage of the time, and who will be helping us achieve that better. We didn't look at the nuances as which malignancy was missed out more often. So that probably we can look at it.
Can I answer that, and maybe Tanya madam can verify that? Mucoepidermoid low grade are more likely to miss. If there is more mucoid element, then it's difficult to comment upon.
Honestly, I didn't look at that, but maybe we can look at it.
So this is, even I'm not saying this out of numbers, just what I've seen.
Yeah.
10 minutes कहाँ से हो गए?
Thank you.